to say something, and then I'll jump in for an introduction. So if you're okay, I'd like to start now.
Yep.
Good morning. This is Vicky Frazier, and I want to take a moment before we start Grand Rounds this morning to address the incredible sadness and grief that we're all feeling over the death of George Floyd, and the tremendous stress and sadness that everyone is feeling, not only because of COVID, but because of the ongoing police brutality and racist acts that have led to another death of an innocent individual. It would not be a surprise to all of you that this is not a new problem, that this has been going on for decades, and that over the past few weeks we have seen an escalation in death and violence and ongoing racist acts that have impacted the Black community. As you all know, as healthcare workers, you see every day the health disparities that impact the Black community, not by their choice, but because of systemic racism that has occurred in this country, that's created food deserts, that's limited access to healthcare, that's led to mass incarceration and disproportionate inequities in educational options for Blacks. And we wonder, how can this continue? But it continues because all of us had not stood up. This cannot be left to just the diversity and inclusion community to act out. It has to be all of us standing up, learning more about racism, understanding our roles, our responsibilities, becoming more effective upstanders and allies for the Black community, for saying out loud that Black lives matter, to be willing to stand together to make real change happen. So I have still great sadness about what's going on, and I have been struggling about how to speak, but I think we can all do more, and I will begin with me. So I commit to speaking out more, to standing up more, to donating to the NAACP, to using Black businesses for my purchases, and advancing our hiring, recruitment, promotions for Black individuals, to ensuring that we have equity in the workplace. And I would encourage all of us to reach out and to support our community here at Washington University, in the hospital, in the St. Louis region. Life is incredibly difficult right now. It was difficult because of COVID, and now it's even more difficult. So I need all of us, all of you, to be even more compassionate, to show support, to cut people slack, to ask how people are doing, to find ways to show support for the Black community. And engaging in peaceful protests, if that feels right to you, is a good thing. Please just wear masks, try to encourage people to remain socially distant while protesting, so that we don't make it even worse with COVID in the Black community here. So I know we can do better. This is a great institution. The Department of Medicine has extraordinary faculty, trainees, and staff, and we will work together to make real change in the future. So I appreciate each and every one of you standing up, being an ally, and helping us make real change in the community. So now I'd like to introduce Dr. Adam Lick, one of our extraordinary chief residents, who has really gone above and beyond all year, but particularly now with our Grand Rounds series, creating ways to transform Grand Rounds into a totally Zoom and online presence, and who has really worked extraordinarily hard to find great speakers, each and every week. And today is no exception. He's identified two exceptional physicians from the Pulmonary Critical Care Division who've been working in the COVID ICUs to talk about their experiences with COVID-19 and critical illness. So, Dr. Lake, thank you.
Thank you very much, Dr. Frazier, for those kind words. I would be remiss if I didn't include our man behind the scenes, Terrell Fields, who, without him, none of this would be possible. Who's been here every day and essentially troubleshoots our Zoom, and I would be completely lost without his help. So,
Terrell, thank you.
Good morning. Welcome to Medicine Grand Rounds. Today marks our last Grand Rounds until we resume in August after the summer break. This morning, we'll finish our lecture series on COVID-19 with a discussion on the overview and outcomes of critical illness. We are joined by two of our expert colleagues who will guide us through this topic, Drs. Patrick Lyons and Colleen McEvoy. As a reminder, please use the chat function on Zoom to ask questions. I will be more than happy to coordinate a Q&A session after the talk. All QR codes will be available during that time as well. And starting off, Dr. McEvoy graduated cum laude with her MD from the University of Missouri-Columbia School of Medicine and was awarded membership into Alpha Omega Alpha Honor Society. She then completed her residency in internal medicine at Northwestern University in Chicago before journeying here to WashU for a fellowship in pulmonary and critical care medicine. Of note, she won the Best Resident Teacher Award during her time at Northwestern. Currently, she is an assistant professor of medicine in the Division of Pulmonary and Critical Care. She holds a particular interest in pulmonary vascular disease and has helped form the Pulmonary Vascular Disease Clinic, which is accredited as a center of comprehensive care by the Pulmonary Hypertension Association. She is also interested in the treatment and approach to pulmonary arterial hypertension and has worked with fellow specialists and other leading centers to conduct therapeutic trials. She currently holds a clinical interest in the development, prevention, and management of pulmonary graft versus host disease after bone marrow transplantation. She currently is working with the BMT group to develop an approach to management of GVHD. Following her is Dr. Lyons, who obtained his MD with honors from the University of Chicago School of Medicine, where he was elected also to Alpha Omega Alpha and the Gold Humanism Honor Societies. He completed internship, residency, and chief residency in internal medicine at the University of Chicago, followed by clinical and postdoctoral research fellowships in pulmonary and critical care medicine here at Washington. During those fellowships, he earned a Master's of Science through Washington University's Mentor Training Program in Clinical Investigation. This year, he has served as one of the first Healthcare Innovation Fellows within the Healthcare Innovation Lab at BJC Healthcare. Currently, he's an intensivist and physician scientist with research interests in clinical research informatics, biostatistics, healthcare delivery, and learning health systems. His current research involves the creation, evaluation, and implementation of risk prediction models for hospitalized patients with cancer and leveraging health information technology to improve care transitions for high-risk patients. It is my great pleasure to welcome both Dr. Lyons and Dr. McEvoy as they present COVID-19 related critical illness, an overview and discussion of BGH outcomes.
Thanks, Adam. Good morning, everyone.
Thank you. Good morning. So we'll start off. We're going through this presentation. We'll be back and forth to talk about the experiences here at Barnes with COVID in the ICU, and then just an overview of critical illness. Let me take my mask off for a second. We have no relevant disclosures. First, we'll talk about the COVID ICUs and the development that happened very rapidly, as we all know, as this novel virus, ascended upon the U.S. Talk about the epidemiology related to critical illness and the variant organ failures. They're really related to the way that the SARS-CoV virus enters the cells. It enters through the ACE converting enzyme, as we've all learned, and that resides on the endothelium of many of our organs and is how we start to see some organ dysfunction. We'll also talk about the recovery from critical illness. So on March 16th is when we opened our first COVID ICU. It was 15 beds, and we used 8,200 based upon the airflow system of 8,200. And then about a week and a half later, we opened 8,300. And then shortly thereafter, 8,400 and 10,400, with a total of 75 COVID ICU beds. And really, when we look at the development of the COVID ICU, it certainly takes a lot of teamwork. It was very multidisciplinary. Our teams had to be incredibly flexible, and I think they got tired of hearing me say, you know, thank you for being flexible. I think most people are able to do the splits at this point because they've been so flexible as we've made numerous changes throughout these last few months. It took constant communication and some self-reflection on how can we employ this and use our strengths as an institution and as a division to care for these patients. Not just the COVID ICU patients, but our non-COVID ICU patients as well, and maintaining our level of standard of care for those patients too. There are specific challenges that came about with COVID, and number one was, of course, infection control. We first needed to define what is an aerosolized generating procedure and how do we address those aerosolized generating procedures. Things from suctioning to bag mask ventilation and intubation, CPR, use of nebulized medications was all aerosolized generating. And we needed to ensure that our staff had appropriate PPE, but certainly with the training of donning and doffing. It is new to us to undergo donning and doffing for every patient interaction we have. And there was certainly a level of fear there, and so addressing that. Then we needed to look at how do we standardize care for these patients. We're learning on a minute-to-minute basis as new information is coming about. There's been well over 10,000 articles on PubMed published on COVID in just a few months period of time. So how do we look at that? We developed the COVID Critical Care Task Force that I co-led with Dr. Tiffany Osborne. And with that, we tried to evaluate specific critical care important decisions. So when to intubate, and that evolved over time, and Dr. Lyons will discuss some of that. Also, how do we manage our airway? At that point in the early beginnings, we did early intubation, all through RSI by the most experienced provider with no bag mask ventilation, which also took education for our respiratory staff and our nursing staff, because this is slightly different than what we're used to. We also talked about non-invasive ventilation and high-flow nasal cannula, and that evolved over time as well. We developed ECMO guidelines and also guidelines on cardiac arrest. We had weekly COVID conferences, shared files. Dr. Lyons developed the ICU COVID handbook, and there were just constant emails to keep everyone up to date on how to manage these patients in a more standardized fashion. This was very multidisciplinary. It involved emergency medicine. We had all of the ICU directors from neurocritical care, cardiology critical care, CT surgery, surgical critical care with our anesthesia colleagues and surgical colleagues, and then also with respiratory therapy as well. We also developed a multidisciplinary approach to rounds. We tend to practice multidisciplinary, but not necessarily as a formal rounding practice. And so with COVID, we knew that our colleagues were learning information in their specialties just as we were learning information in ours, and wanted to make sure that we were all up to date on how to manage these patients. So there were daily rounds that occurred with ID, renal, heart failure, and many times palliative care. Key to this was also minimizing healthcare worker exposure and conserving our PPE. And so efforts were made in order to do that with numerous discussions with the Incident Command Center and our nursing colleagues. Efficient use of ICU time was also one of the important factors here. At one point, our peak admissions in a 12-hour period was 22 admissions. which is a lot of ICU admissions for a 12-hour period. So we developed a PAC-19 team was the name of it. It was our anesthesia colleagues who had not been in the ORs, and so were available for intubations and procedures, which help allow the intensivists on the ground to focus more on the medical management, ventilator management of these patients. E-care manager and EICU were critical to helping minimize our exposures and conserving PPE, and also allowing family visits through video visitation. We tried to bundle our ICU care, again, in the efforts to maximize our efficiency in the ICU, and so there were a lot of work that went into that. We also needed to develop a surge plan. We had seen what our colleagues had undergone in New York and Washington and California, and we had a little bit of time to think about how can we handle our surge capacity. And so there were preparations for moving into PACUs and non-conventional ICU spaces should we need to. We developed a physician staffing model that would allow us to flex up, and this was based upon the Society of Critical Care Medicine's pyramid model that I have here. With that model, we rely on our fellows, our APPs, and hospitalists to be able to flex up to care for a number of patients, one intensivist to many patients. Resource availability was certainly something that was on the minds of everyone, whether or not we'd have enough ventilators to care for our patients. And so there was daily and sometimes hourly updates on the number of ventilators throughout the BJC system. Our innovation lab and others from our pulmonary and critical care division worked on ventilator development and how to develop a ventilator with some of the engineers locally, and also ventilator sharing strategies. If we needed to use one ventilator for 2 patients, how would that look, and how could we employ that if needed? Nursing and RT were also key to managing these patients, and they had to undergo rapid training for COVID-specific management. They developed these cards on every ventilator and non-invasive ventilator that discusses how to use the viral filter, how to keep it more of a closed system. We wanted to make sure that we minimize any break in the system, particularly going from intubating a patient to moving directly to the ventilator. So a lot of work went into that. We also needed to discuss things that were difficult and look at the phases of altered standards of care, and what phase were we in, when would we decide what phase we would move to. And so teams were developed to discuss that, and then also with triage officers if we needed to move towards major alterations in standards of care. Luckily, we did not hit that point, and hopefully we won't in the near future. Special considerations, certainly we've all been affected by the restricted visitor policy. This certainly hits home very hard in an intensive care setting where families need their loved ones at the beds, or loved ones need to be at the bedside for the patients. It also develops relationships with the team. Loved ones see how much we care for their patients, how much work we're putting into it, and they aren't there to see that. And so it's not able to develop a level of trust that we are used to employing in the ICU. So we worked hard to do telephone and video conferencing as an alternative and try to keep our means of communication very open. We also use point of care ultrasound to minimize imaging. We, again, want to protect our healthcare workers, and so trying to minimize the number of chest x-rays, lower extremity duplex, echocardiograms, and we have a pretty robust team of intensivists who have trained our fellows and the rest of our staff for use of point of care ultrasound, and that had already been in place prior to COVID, and so that was a huge resource that we relied on. Our non-clinical support staff were also very, very helpful in helping with scheduling, keeping track of where everyone was. At one point, we had 10 intensivists scheduled per day, which is a lot of intensivists to have in a COVID ICU. We also needed to have fresh scrubs, showering capabilities, meals. So I can't thank them enough. And as Dr. Frazier pointed out, this is a really rough time. We are in uncharted waters, and management of our staff wellness is certainly something we don't want to dismiss. So we employed resources for meditation, for Zoom yoga. There is a peer support network through Washington University that all of our ICU attendings have been paired with a peer supporter to help guide through some of these difficult times. And then our psychiatric colleagues have really had a robust development plan for helping care for mental health of healthcare workers. Moving on to more things about critical illness. There's been definitions really on what defines a severe and critical disease. Now, this is really a continuum, but in really for purposes of clinical trials is where we see what defines severe versus critical illness. Severe is really a respiratory rate greater than 30, an SpO2 less than 93 on room air, your P/F ratio less than 300, and rapidly progressive chest X-ray findings greater than 50%. Critical illness is respiratory failure with the need for mechanical ventilation, shock, or any organ system function that requires ICU admission. Risk factors for severe disease we've all become very familiar with is age greater than 60, comorbidities including cardiovascular disease, chronic lung disease, and immunocompromise, and the obese. Warning signs for progression from severe to critical. We tried to really disseminate this information. There had been a number of anecdotal stories of people being intubated in elevators because of rapid deterioration. And so things to watch out for would be new hypoxemia, rapidly increasing oxygen requirements, altered mental status, tachypnea. And then looking at the lab values, a rising CRP, elevated D-dimer and ferritin, decreasing lymphocyte count, and troponin. Older age, elevated D-dimer, troponin, and higher SOFA scores were associated with in-hospital mortality in these patients. Move on to Dr. Lyons to talk about the epidemiology.
Thanks, Dr. McEvoy. So, as we'll discuss, a significant minority of COVID patients will end up developing symptoms that require hospitalization, usually about a week after their initial symptom onset. It's been a bit challenging to get a full handle on what happens to all these patients in real time, in large part because the denominator remains uncertain. When the paper I'm showing here was published in March, almost 40% of the critically ill patients did not yet have their outcomes determined. So thanks to several large observational studies, the one on the left, the Society for Critical Care Medicine Registry, of which we're a part, and then a recent publication out of NYU shown on the right, we now have an idea that between 1 in 5 and 1 in 3 hospitalized patients end up being admitted to the ICU. Keep in mind that there will be inherent variation across nations and on the more local scale based on the number of ICU beds, capacity strain, practice patterns, and so forth. There certainly is variation in outcomes too. The New York group reported mortality of over 65% in critically ill patients, and over 50% in those who elected to go to the ICU versus electing hospice care on the wards. While the group at Emory in Atlanta on the right appears to be seeing mortality between 30 and 40%, at least after all their remaining patients will be discharged or will have passed away. This may be due again to practice variation, as well as things like time to prepare. Certainly, groups in cities other than New York may have been able to learn valuable lessons from watching our colleagues in those cities go through this early. We also may be seeing differences again in patient volume and available resources, or potentially the comorbid case mix. So here is how our experience compares. On the left are a series of time-based bar charts showing on the top the number of COVID patients, below that the number of PUIs or persons under investigation. Below that would be the patients who have been effectively ruled out for COVID. And then finally at the bottom, the total admissions coming through the COVID ICUs. On the right are their outcomes, and I'll magnify this a bit more. When we compiled these numbers over the weekend, we'd seen almost 1,400 admissions come through the 4 COVID ICUs. Overall, 2/3 of these had survived to discharge, and about 15% had died. Among the 17% who were COVID positive, over half of them had survived to discharge. That's the purple group in the small bar on the far right, and 27% had died, the yellow group in the small bar on the right. And the remainder are in the hospital still with their final outcomes yet to be determined. The demographics that we see match those that have been reported elsewhere. On the left, looking at age, we know that COVID patients tend to be older than non-COVID patients. The median age is also higher for those who died, highlighted in red at the very bottom of that table. The figures on the right mirror each other in their layout. The far right panel shows the COVID positive patients, while the left-sided panel shows the COVID negative patients. The top figure represents the racial breakdown of our patients, with the blue bars representing patients who self-identified as Black, the green bars representing those who identified as white, and then the red bars representing those of other races. And as has been seen elsewhere, and as Dr. Frazier mentioned at the beginning of our talk, COVID has disproportionately affected Black patients in the ICU, regardless of their ultimate outcome. The bottom figure shows the gender breakdown, with slightly more male patients in red than female patients who are teal. And again, this is consistent with what's been seen across the nation. And in this box whisker figure, again, with the positive patients on the right and the COVID negative patients on the left, we can see that the outcomes by both race and age tended to sort of work against patients who had older age and then those who self-identified as Black race. Now, we've hinted at this already, but the majority of critically ill COVID patients have experienced respiratory failure and have received mechanical ventilation. This table from the Emory study we showed you earlier illustrates that clearly. 3/4 of their patients overall, including 2/3 of survivors and 90% of decedents, were ventilated. And so this brings us to a rundown of the organ failures that we're seeing in the ICU. And we've listed them here, but we'll start and mainly focus on the respiratory system. COVID in the lungs is predominantly a disease of the air spaces, at least as we know it right now, and it causes hypoxemic respiratory failure. The CT images here illustrate classic findings: peripheral, patchy, bilateral ground glass opacities. The table on the right should highlight some of the key features that may distinguish COVID from other viral pneumonias, including the peripheral distribution, the presence of reticulations, and vascular thickening. Findings like pleural effusions and lymphadenopathy would be very inconsistent with COVID and might help argue against it and in favor of some other viral pneumonia or another cause. We need to learn a lot more about the pathology underlying COVID lung disease. And I know some of our colleagues here, including our division director, Dr. Holtzman, have been working very hard on this. This case series shows small numbers of COVID autopsies, and they're generally consistent with their findings of diffuse alveolar damage with hyaline membranes and squamous metaplasia, both of which are features of ARDS, acute respiratory distress syndrome. What's interesting is that 2 of these studies found extensive venous thromboembolic disease, while the third did not mention any. So I think this underscores an area needing a lot more investigation, especially given the discussions we've seen regarding thrombosis and coagulopathy in COVID, including here at a prior grand rounds with Dr. Sanfilippo and Dr. Binder. One of the main challenges we faced, and Dr. McEvoy underscored this earlier, particularly early in the pandemic, was the decision around when and if to intubate a patient. And as this table suggests, different institutions seem to have taken a different approach to this question. We see mechanical ventilation rates that range from 30% all the way up to 90%. Based on some of the concerning anecdotes we'd heard from colleagues in other cities and countries, We were certainly on the lookout for patients experiencing rapid deterioration, going from, say, 4 liters per minute of oxygen to 15 liters over a matter of minutes to hours, and we wanted to avoid emergencies if possible. We also knew then about the potential for aerosolization peri-intubation, and also had concerns about aerosolization of the virus with non-invasive devices like BiPAP. Certainly, aerosolization could be a risk to staff. We had to balance all of these concerns with the known opportunity costs of mechanical ventilation. Mechanical ventilation isn't a benign intervention. Certainly, there is a ventilator-associated lung injury that can occur, and sedation has a cost. And being on the ventilator, patients may miss out then on the avoidance of things like sedation, other invasive procedures, and so on. So we know that COVID patients develop hypoxemic respiratory failure. And initially there was some controversy around whether this represented true ARDS. And as a quick reminder, acute respiratory distress syndrome is a clinical construct, a syndrome defined as acute hypoxemia with a PaO2, so the pressure of the O2 in the arteries, and the ratio of that to the fraction of inspired oxygen on the ventilator. So the ratio of less than 300, going along with bilateral airspace opacities that really aren't explained by high cardiac filling pressures like congestive heart failure. And as you can see here in this table, some prominent authors made arguments for a new clinical construct along with a set of kind of quote phenotypes of respiratory failure, and advocated changing our standard practices, suggesting tailoring to fit a high lung compliance and a low lung compliance, or an H and L phenotype. And we'd like to take a few minutes to say a few words about that and what we've learned so far. So first, as to the issue of lung compliance, this is a standard measure of how a lung changes in volume based on a given change in pressure. So it's the delta V over delta P. And low compliance would generally mean stiffer lungs. The figure on the right is from the original ARDSNet intervention paper 20 years ago, showing that static lung compliance had a wide distribution, meaning that not all ARDS lungs are stiff, and that compliances at many levels seem to benefit from a key ARDS strategy, which was lower tidal volumes. And in fact, this series of trials showed us that this idea of lung protective ventilation, smaller tidal volumes, appropriate levels of positive end expiratory pressure, permitting hypercapnia, and then pairing that along with things like dry lungs, negative fluid balance, will all benefit patient survival. We also know that things like prone positioning can do this, and we'll say more on that in a moment, and that the effects of our sedative management can be very significant on patients. So arguing for a deviation from these standard practices would be certainly a substantial change in what we're doing in the ICU. So these figures have come from the Harvard hospitals, specifically from their case series of about 70 COVID patients. For all of the figures, the x-axis is the day in the hospital, day 1 through day 5, with the patients on the ventilator, I should say. And on the left, then, we can see that the y-axis has the P to F ratio. And I drew a blue line to represent the cutoff for ARDS. So most of the ventilated patients met ARDS criteria on all of the hospital days. In the middle is the PEEP, the positive end expiratory pressure, and the numbers here are fairly standard. And then on the right is the respiratory system compliance, which has a large range of both low and normal values without clearly falling into any two kind of well-defined camps or clusters. So, the idea that COVID respiratory failure isn't really ARDS, or that the lung compliance tends to fall into two well-defined categories isn't well supported by this evidence. It may be true, but certainly we haven't seen a lot to show us that other than a few anecdotes. So in the end, I think we learned some key lessons here. The idea of phenotyping a clinical syndrome is a great one, but at least for COVID, it may be premature to do so. Even among the well-described clinical and biologic ARDS phenotypes that we've seen from before COVID became an issue, it's not totally clear that tailored treatment has shown a benefit for all patients as of yet. And so I think what we've learned is that we really need compelling evidence to abandon the things that we know work. And speaking of things that we know to have a benefit, let's talk briefly about proning patients. So proning patients, or as we called it on rounds in the ICU, tummy time. involves placing the patient face down for many hours during the day, ideally about 16 hours out of a 24-hour period. Physiologically, this has been shown to decrease posterior atelectasis and to improve lymphatic drainage, and that's basically been the rationale for using this as therapy in patients with ARDS and bad hypoxemia. And so in 2013, a large randomized controlled trial showed a mortality benefit in patients with ARDS who had a P to F ratio of less than 150. And the Kaplan-Meier curve is shown here for that study. So we've been doing this for COVID patients fairly aggressively. Certainly many of the patients that we've seen fall into this P to F range. The figure on the left shows improvement in ventilation and perfusion matching after a COVID patient was proned, which I think is an interesting finding. And in fact, this has been so compelling that there are now some early data emerging for proning patients who are not on the ventilator in order to avoid intubation, essentially asking the patient if instead of laying on their back or sitting semi-recumbent, if they can lay on their abdomen for a period of time. And we've done this with some anecdotal success here, both in the ICU and on the COVID wards. The figure on the right shows one of these small series in which about half of patients had some physiologic response to, as we call it, self-proning. Not all patients can stay comfortably in this position, and so certainly it needs to be something that the patient can tolerate. And I think patients need to be continually assessed and monitored closely while doing this. But it is an intriguing idea, and I think we'll learn more about that over the coming weeks and months. So as I mentioned earlier, because of incomplete follow-up, we're still looking at ranges of mortality for the ventilated patients. The most recent publication on this from Emory last week suggested a mortality of mechanically ventilated patients of about 40%. And I think it'll be interesting to see how these other sites with still many patients receiving care whose outcomes haven't been determined, it'll be interesting to see how they end up comparing to the traditionally quoted ARDS mortality that falls somewhere between 25 and 35%, but most recently around 30%. Our own experience here in the COVID ICUs matches this fairly closely. So on the left here is a table of our patients who have received invasive mechanical ventilation and those who have received none of that. And then we see who has died, who remains in the hospital, and then which patients have survived to discharge. And these are then recreated here in the figures on the right with the COVID positive patients in the far right panel and the COVID negative patients in the leftmost panel. And we see that just over a third of the patients on the ventilator with COVID have died already, and another 20% remain hospitalized. But we know that over 40% have survived to discharge, and I think more will as well. We have seen over 120 patients intubated with COVID at this point, so our numbers are quite robust, and I think we'll be taking this to publication sometime soon. In terms of proning, both intubated and non-intubated patients, the mortality floor appears to be about 30%, with a few additional patients remaining in the hospital. And certainly we've seen that far fewer patients have been proned who haven't had COVID. And these are patients who have had ARDS that's been defined by some other pathogen, either a pneumonia or sepsis-related ARDS, where it's had a pretty clear picture that what they were experiencing was not COVID. One other point to make here is that the duration of critical illness seems to be long, and anecdotally a bit longer than we normally would expect out of patients with severe disease. And in particular, this is true about the duration of mechanical ventilation. So again, these numbers are from our own ICUs, and on the left we note that the ventilated patients who survived were on the ventilator for a median of 13 days, so basically 2 weeks. And on the right, we see the ICU lengths of stay for both the ventilated on the right and the non-ventilated patients on the left, with the red dots representing the survivors and the blue dots representing patients who had died. The mechanical ventilation patients have quite a bit of time in the ICU. So as Dr. McEvoy has shown, and as we've reviewed with some of these outcomes, we've seen a lot of work go into care for these critically ill patients. And what's interesting is that things do seem to be getting a bit better. The figure on the far left here is actually basically looking at the hospital census and the ICU census in New York City over the month of March and then in early April. And we can see that it started to come towards a peak after the first week of April. And then on the far right here is a table from the observational NYU study that we talked about earlier. And what they're showing here is actually a multivariable prediction model to look at the risk of developing critical illness. So not the critical illness outcomes, but the risk of patients becoming critically ill. And we see that as time went on, after controlling for a number of important variables, the risk of becoming critically ill got a lot smaller. And they actually found non-significant trends towards the same finding of declining mortality without changes in the risk of hospital admission. And so I think the inference that's being made here is that it's not that something is different pre-hospital for patients, but that something may be different in the hospital for patients. And explanations for that could include capacity strain as new wards open. It could also include allocation of resources, disposition decisions in the emergency department, but also changes in care delivery, things like more aggressive proning, non-intubated patients avoiding intubation through non-invasive ventilation or through proning, or changes in therapy that are targeted towards COVID, such as the addition of remdesivir, consideration of anticoagulation, or avoiding things that may turn out to be harmful, as we've seen some early signals about that with potentially hydroxychloroquine. So I think some interesting lessons here and things to consider, but certainly striking data, particularly since we know that this is the busiest time in the New York hospitals. And so it's not that even in settings of scarce resources, the outcomes were worse. In fact, if anything, they might have been better. And so I agree with this takeaway that we seem to be learning very quickly. And I think the idea that we must be flexible and learn fast should be one of the big takeaways from our own center experience here. We've incorporated some of these important lessons, and I thought I would illustrate them by showing this slide that I shared with our fellows in March, right at the beginning of the pandemic here, which highlighted both some of the traditional therapies we should be trying to use, as well as things we would try to avoid, such as avoiding non-invasive ventilation, avoiding high-flow nasal cannula like Optiflow, and trying to intubate patients essentially electively very early in their illness to avoid emergencies. And certainly over the last 2.5 to 3 months, we've seen a lot of this change. We're now using these therapies judiciously, and we seem to be doing so safely. We've avoided this idea of early intubation and instead are basically letting the patient's clinical trajectory inform us as to when it's time. And that seems to have gone well without any untoward effects. And this is again to say nothing of the other changes in therapy, such as proning non-intubated patients, the expanding availability of remdesivir, moving away from other therapies that didn't seem to be helpful. And so I really think we can look forward to learning a lot more about this over the coming months, and I hope this will further improve the care that we're delivering. And so with that, I'll turn it back over to Dr. McEvoy, who's going to speak a little bit about some of the other organ systems involved.
Thank you, Dr. Lyons. So talking as we move through about acute respiratory distress syndrome, we have to talk about extracorporeal membrane oxygenation, ECMO. And certainly we use this for refractory respiratory failure in non-COVID times. There was some early data that use of ECMO resulted in an 86% mortality rate for those that went on ECMO out of a case series from Europe. So there was significant caution on using ECMO. However, again, as things have evolved, we've learned a little bit more about patient selection. Those patients that had higher mortality out of that case series had decreasing lymphocyte counts and some other markers for severity of illness that would have maybe not made them great candidates. And so our ECMO colleagues here really worked hard and with our critical care task force to develop ECMO guidelines. And we are part of the registry internationally for ECMO patients. And overall, you can see here, this is from early this week and is up to date, that there's been about less than 1% of COVID patients on ECMO. And it has had a fairly good mortality rate for those that have been discharged. Now, there are still a number of patients that are still in the hospital. So again, wondering about the denominator here, but the mortality was 53 or 50%. And so that isn't that different than what we see in traditional ARDS. And Some of the other complications that are quite common with ECMO include intracranial hemorrhage, which was 5%, and renal failure at 24%, but that is along the lines of percentage for renal failure in critically ill COVID patients. Here, the predominance is on VV ECMO, highlighting the need for mainly respiratory failure, although there are a number of cardiovascular complications, which I'll discuss in a moment. The main reason for ECMO has been VV ECMO. Interestingly, thinking about these patients, there's going to be more discussion about cytokine storm and when these patients go on to ECMO. There's some older data back in 2008 of cardiac surgical patients that went on ECMO and looking at their IL-6 levels. And they found that survivors had decreasing levels of IL-6 and non-survivors had higher IL-6 levels. Again, this is in non-COVID patients, but I think it goes along with some of our experience here. And I know that we've given tocilizumab to a few of our ECMO patients with some success. Moving on to cardiovascular complications, I certainly am not going to go through all the cardiovascular complications because our great colleagues, Dr. Levine and Dr. Schilling, did a wonderful grand rounds discussing it, but just to highlight that there are a number of things that we see in COVID patients. Certainly having a history of cardiovascular disease increases your COVID risk and also increases the severity of illness. We tend to see elevated IL-6 levels, D-dimer, ferritin, and LDH, along with the cardiovascular complications. Elevated troponin was seen in 22% of ICU patients and was associated with mortality, which you can see the graph here on the right. Those without cardiac injury had a much better mortality than those with cardiac injury. And whether the cardiac injury was related to actually coronary occlusion with a STEMI, myocarditis, or stress-induced cardiomyopathy, we don't have enough numbers to really tease that out. We have seen significant dysrhythmias in the ICU. 44% of patients in the ICU have had arrhythmias, 12% of them malignant. Certainly acute heart failure and viral cardiomyopathy have been seen, and they tend to be more of a later complication after recovery from ARDS. And it's unclear why that is, and the pathophysiology is still being reviewed. Renal complications are also quite common. Now that is not dissimilar from critically ill patients in general. But overall, when the Chinese looked at their literature, they had greater than 40% of their hospitalized cases with proteinuria. Some had hematuria. And then combining the Chinese and US literature, the degree of acute kidney injury was 20 to 40%. It again is a marker of severity and a negative prognostic factor for survival. The need for renal replacement therapy was about 20%, which anecdotally at our institution is similar. We don't have those exact numbers quite yet. It also tends to occur at about a median of 15 days after illness onset, which correlates with respiratory failure. Respiratory failure tends to happen about the 10 to 14 day mark. And those with pneumonia and who develop acute kidney injury also do worse. The reason for acute kidney injury and renal complications is multifactorial as it usually is, but we do think that the actual virus may play a part in this, and there have been viral particles that have been present in renal cells at the endothelial level, again related to the entry of the SARS-CoV-2 virus through the ACE2 receptor and that pathway. Certainly other things can affect the kidneys besides the endothelial damage, and that may relate to the cytokine storm that we're seeing, and also related to pneumonia. Hypervolemia certainly plays a role in our critically illness in patients. And myocardial dysfunctions, since we've seen low cardiac output in a number of patients, that affects the kidneys. Early on though, patients may actually be hypovolemic. quickly go through, this is some of the data outside of China, US data looking at those with risk of AKI and need for renal replacement therapy. Certainly they have higher numbers of comorbid conditions. Thromboembolic disease is one that cannot go without mentioning, but again, Dr. Sanfilippo and Dr. Blinder gave an excellent grand rounds on this, so I'm going to cruise through thromboembolic disease as it is quite complicated. The neurologic complications may be many, but really to discuss delirium. Delirium is an increased risk in the ICU, but certainly in COVID, there are many factors that may cause delirium, and that's the majority of patients that we are seeing. It may be due to direct CNS invasion through the viral particles, induction of the inflammatory mediators, again through cytokines, and of course, secondary effect of other organ system failure, just like we see in sepsis. Patients were more sedated, mainly because, or a couple of reasons, trying to minimize healthcare worker exposure into the room and titration of drips. Also, due to the severity of ARDS, required higher levels of sedation. These patients are on mechanical ventilation longer, as Dr. Lyons mentioned. They are immobilized. We've had difficulties with our physical therapy because, again, we're trying to minimize healthcare worker exposure. And so our patients aren't receiving as much PT/OT as they typically would. And then environmental factors. They don't see their loved ones. They've had limited interaction. And that plays a role into their delirium. I'm going to spend a few moments talking about something that I find incredibly interesting and care for frequently in the BMT ICU is cytokine release syndrome. We have a great experience here at WashU through the BMT and Dr. Armin Gabati and his colleagues being at the forefront of CAR T therapy. And so are very familiar with cytokine release syndrome. And there's been a lot of talk in the lay press as well as in the medical literature about cytokine storm in COVID. And what does that mean? Just to quickly go through, cytokine release syndrome is a physiologic response following immune therapy that results in activation or engagement of T cells and other immune effector cells. It's really a clinical syndrome related to CAR T expansion and elevation of inflammatory markers and cytokines that can quickly progress to vasodilatory shock, capillary leak, hypoxia, and multisystem organ failure. It typically occurs 1 to 14 days after infusion and occurs in majority of patients who receive CAR T, with about 20 to 30% having grade 3 or higher. We have discussed how to manage these patients, and really the management of CAR T CRS is still not quite clear yet. Part of a group through the OnCARnet is a multi-center group to look at CAR T management, but again, we still don't know how to manage this syndrome very well, even in something that we understand a little bit better than COVID cytokine storm. The physiology is really related to the endothelial and myeloid cells that are important mediators. And toxicity occurs after there's interaction between the CAR T and its target that causes activation and expansion of the cells and lysis of normal tumor cells. That leads to release of cytokines like interferon gamma and TNF alpha, and then leads to a downstream effect of activation of monocytes and macrophages. And that leads to high levels of pro-inflammatory cytokines. The TNF beta and interferon beta and TNF alpha are associated with higher SOFA scores, and CRP is used as a biomarker for diagnosis. Understanding cytokine release syndrome is really looking at as interferon gamma and TNF alpha are activated, this causes this release mainly of IL-6 that leads to downstream effects and multisystem organ failure. It is similar to what we are seeing with COVID, particularly in terms of coagulopathy, pulmonary edema, cardiac, renal, and hepatic dysfunction. Cytokine release syndrome affects all organs. The hallmark features, though, are fever, hypotension, and hypoxemia. You cannot have cytokine release syndrome without having fever. Just briefly looking through CRS in the CAR T population, these are the landmark studies for CAR T. And as you can see here, CRS occurs in majority of patients with high degrees of grade 3 CRS. And a number of patients require high-dose vasopressors, mechanical ventilation, and renal replacement therapy. The grading system for CRS has evolved over time, but again, really reflects on fever, hypotension, and hypoxemia. There's a lot of discussion in CAR T patients, is it CRS or is it sepsis? And certainly we need to focus on the patient. A neutropenic patient that has had numerous lines of chemotherapy has risk of developing infection, and concomitant infection and CRS pose diagnostic and management challenges. There are a number of patients that have had infections, 41% severe and 4 life-threatening or fatal infections after CAR T. This again just reflects that CRS may be a marker of infection and not just a cytokine storm we see typically related to the CAR T. So bringing us over to COVID, is it CRS and COVID? And then how do you define that? And is it CRS or is it macrophage activation syndrome or secondary HLH? Just as a reminder, HLH is a hyperinflammatory syndrome characterized by fulminant and fatal cytokine release and multisystem organ failure. You see fever, cytopenias, and elevated ferritin. But here we see that in COVID. However, in HLH, you have classically organomegaly, you have less pulmonary involvement, and COVID is really defined by its pulmonary involvement, vascular permeability, diffuse alveolar damage, vascular dysfunction, and microthrombi, which are not typical for secondary HLH, but can be seen. So what do we know about cytokine storm in SARS-CoV-2? A little bit. I think it contributes to ARDS and multisystem organ failure related to this dysregulation, exaggerated response. In vitro, there's delayed release of cytokines and chemokines that occur in the respiratory cells at an early stage of infection. And then later you see higher levels of interferons and pro-inflammatory cytokines. And we have seen that this occurred in MERS as well. Looking at the cytokine profile specifically in COVID, this is a paper from China that looked at CRP and IL-6 levels, and there was a difference between survivors and non-survivors. In the green, those are those patients that were discharged, and the orange are those patients that died. And so certainly we see that there is a difference between the two. But what I want to highlight is that there is an increased level in pro-inflammatory through the Th1 response, but we also see an elevated Th2 response. So do we inhibit the immune response or do we stimulate the immune response? There's a number of questions, and it depends on which phase of illness, and we certainly haven't looked clinically at biomarkers to determine what phase of illness the patient is in order to modulate the immune system in the appropriate manner. This is a schematic of the inflammatory phase in COVID-19 and is related to the SARS-CoV binding to the receptor and then release of NF-kappa B, and again, downstream effects of the cytokines, particularly IL-1, IL-6, and TNF-alpha, which leads to where people want to modulate the immune system. One such agent is Anakinra. Anakinra is an IL-1 receptor antagonist that blocks activity of IL-1 alpha and IL-1 beta. It had been studied in a phase 3 study of patients with sepsis who had more of this hyperimmune HLH response that showed some benefit. In patients with COVID-19, they did a study looking at moderate to severe ARDS with hyperinflammation, and they were managed with non-invasive ventilation outside of the ICU. They were randomized either to placebo, low dose, or high dose Anakinra. And at 21 days, the survival was 90% in the high dose Anakinra group versus 56% in the standard treatment group. It allowed patients to be mechanical ventilation free, which was a goal really of this study. This was at a time in Italy where they had a lack of ventilators and lack of ICU beds. And so keeping a patient out of the ICU and off the ventilator was certainly survival benefit and may be beneficial to many patients. Quickly moving on, you can't talk about cytokine release syndrome without talking about tocilizumab, which we'll use very frequently here in the BMT ICU. But tocilizumab is really a recombinant humanized monoclonal antibody to IL-6 receptor. It binds soluble and transmembrane bound IL-6. It's approved for CAR T. What I like about this schematic here is IL-6 blockade may be beneficial, but it could potentially be harmful. Again, it depends upon the phase of illness that the patient is in, and we certainly don't understand enough about cytokine storm in COVID at this particular moment. I think that there's going to be a role for immune modulation, but we don't have good studies to understand that right now. I'm going to quickly pass this back over to Dr. Lyons to talk about recovery in the ICU.
Thanks, and I know we're at time, so this is actually just one slide. And I think the point that we should just make here is that there are a number of really important issues at play as patients recover from their critical illness, both from the patient perspective and from the system perspective. Survivorship of COVID is going to mean increased numbers of patients who require post-acute care, rehab, nursing facilities, home health and therapy, and so forth. And as our colleagues here at WashU, Dr. Skrabowski and Dr. Joint Maddox point out, we may not be able to be prepared to handle this at the system level. These patients also are going to have very specific acute and chronic medical needs, including new medical conditions, frailty and limited functional status, and the cognitive and mental health sequelae of critical care. And so it behooves us to educate and prepare ourselves to care for this unique cohort of ICU survivors as they grow. And in short, really, our work is not done. And so that's all we have for this morning, but we need to acknowledge all of our colleagues who worked alongside us really to stand up these units, to staff them, and excel in clinical care over the last 3 months. We also need to acknowledge those who have supported this effort from a divisional, departmental, and a system-wide standpoint, some of whom are named here, but certainly not all. And finally, we should mention Brian, Kevin, and Keith, who helped us compile this data and sort through some of our care processes in real time. And so here we have listed, gosh, I hope everybody who has joined us in the COVID ICUs, and if I've left anybody off that list, I'm truly, truly sorry. And at this point, I guess I'd like to turn it back over to Adam in case you have anything from the chat box. Thanks.
All right, thank you both very much for taking time today to come talk. I did want to give a brief shout out to you earlier. Cannot forget to thank Sharon Morgan, Kirsten Jones, Megan Dietrich, Katie Sidler, who do a lot of behind the scenes work as well, putting on grand rounds this year. So wanted to give my utmost thank you to them. And then a couple questions, if you guys don't mind, in the time permitting here. So the first question was actually coming from Dr. Frazier, and she was wondering about some of the stories that have been in the press about patients who perhaps have been unable to sense the, I guess, amount of respiratory distress that they've been experiencing, perhaps coming in with hypoxemia that far outweighs what they were feeling at home. And if you guys had any insight into that and any ability to comment on kind of the disconnect there that perhaps we've been seeing in some of these cases.
Sure, so I can comment. I think most of the things that I'll say are anecdotal. I've seen patients over the last 3 months who have looked like that. They're on Optiflow, 60 liters of flow, breathing relatively comfortably, although quickly, and they say they actually feel fine, even though their saturations are still in the 80s, and we're talking with them about intubating them. And there's definitely some cognitive dissonance there. It's a bit disconcerting to see people look so comfortable while they're so sick. In terms of why that goes on, I don't know. I think we have a lot to learn about the pathophysiology of this. And really, is it true impairment of gas exchange? And if so, what's different about this that patients aren't so dyspneic? Or is it something else that relates not just to the gas exchange going on in the lungs and in the pulmonary vascular bed, but maybe it has to do with the virus affecting the way that oxygen binds to hemoglobin or something else. People have speculated about that. But at this point, I'm not aware that it's anything more than speculation. And so I want to raise that as a possibility, but certainly acknowledge that I don't think any of us here have a good answer for that. Dr. McEvoy, anything else you comment on? Yeah, okay.
Next question. Said initially steroids were being discouraged due to concerns of prolonged viral shedding. And it seems that they made a bit of resurgence for COVID. The question being if you could potentially discuss the latest view on corticosteroid use in non-resolving ARDS and what type of patients may be appropriate candidates for that therapy.
Sure.
Yeah, great question. As you mentioned, steroids were highly discouraged due to the risk of viral shedding. That was based on some data, mainly from influenza, and really wasn't based on any data from COVID. And so as we've gained a little bit more data with COVID, the group out of New York had found some benefit in use of corticosteroids in early phases of ARDS. Now, let me mention, though, that all previous studies of corticosteroids in ARDS have been negative, and we do not use routinely corticosteroids with ARDS. So the thought here and the reason behind the evidence of trialing corticosteroids in COVID patients mainly related to the cytokine storm. And correlating that again with the CAR-T CRS patients, corticosteroids is part of the mainstay of therapy for CRS and CAR-T. And so the thought would be to calm the immune system with the corticosteroids rather than necessarily promoting healing from ARDS. And so again, I think it's still more that we need to learn about it. And there may be a select group that would benefit from corticosteroid use.
Okay, in the interest of time, I'll do maybe one or two more questions. There's one specifically asking about perhaps some of the outcomes here. And that question being, did we see a rate of continuous renal replacement therapy drop after we pushed to stop intubating people early?
So the short answer is that we don't have the full set of the renal replacement therapy data available yet. We have the numbers of patients who are on continuous dialysis only, so CVVHD, but we're still working to identify all the patients who received SLED. And so I think any comment on that would probably be a bit anecdotal. But I think that my experience has been that yes, we are seeing a bit less need for dialysis right now, although I want to reserve the right to say that that's just anecdote, and we'll drill down on that as soon as we have the SLED patients identified.
Okay. And last question, perhaps putting on the spot a little bit, but are there any factors that you can think of that perhaps contributed to the large difference between WashU and New York City's COVID-19 ICU mortality rates?
I think there are a few. I mean, I think one of them is that we had the benefit of time and were able to sort of learn lessons from them, as we were a week, 2 weeks, 3 weeks behind them and how this has emerged. And certainly, in addition to the benefit of time, we also had the benefit of at least some lower degree of capacity strain in all of our units. And so we didn't have to go to some of these sort of, salvage models of care delivery, which I'm sure helps. Those might be the two biggest things. It looks to me like the New York group also has a lot of patients that elected not to pursue critical care at the early stage. In fact, if you looked at the 900 and some odd patients that were defined as critically ill, 200 of them never went to the ICU, and it's not really explained what happened to them. I imagine some of them elected to pursue hospice and comfort care, but others may have actually had cardiac arrests on the wards and not made it to the ICU because of that. And so there may be something going on in the pre-ICU setting that we're not entirely aware of yet. And I think it'll be up to us to kind of seek that information as more data comes out. It certainly helped us that when we were opening up these units, the initial COVID floors were immediately below our ICUs, and we were in close contact with the hospitalists, such that I think everybody was very synced up in our care delivery practices from day one. And then that certainly really helped us fly when things got much busier, weeks 3 and 4.
I think, yeah, I think the only other thing too is purely speculative. So with that disclaimer, you know, in New York with the crowded areas, also, I think that there is a degree of severity of illness related to the inoculum and the number of viral particles. And we certainly saw that with the number of healthcare workers that died in New York. And some other states early on, is that it seems to be that they probably had more exposure to the viral particles, and maybe that our early social distancing may have helped those that did get COVID had less of an inoculum than those in New York. Now that's highly speculative, but it's just something to think about.
All right. Well, thank you very much again for taking the time out of your work today to come speak to all of us. Again, thank you, Dr. McEvoy. Thank you, Dr. Lyons.
Thank you.
Yep. For everyone else, this marks the last grand rounds for this year, and we'll look forward to seeing everyone with the resumption in August with our senior residents presenting. So until then, again, thank you all, and thank you specifically both of you for today.
Thank you.
Thanks.